Please start, sir. We are live.
Good evening to all distinguished delegates and our eminent faculty today, Dr. Tushar Roy. And I am Satish Rama Joshilkar from Zydus Medica. Honored to welcome you on this scientific platform called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my most sincere gratitude for your presence in this scientific webinar. Talking about just brief about CLEARTalk is one more initiative from Zydus to unite against dyslipidemia. As you are aware that in India, 1.24 crore Indian population is uncontrolled LDL cholesterol population, and 7 out of 10 patients are having uncontrolled LDL cholesterol. So recent development in the field of dyslipidemia, that is bempedoic acid, which is an add-on choice for LDL cholesterol management. And hence this session of CLEARTalk is focused on one more recent development in ACC 2023, that is late breaking clear outcomes trial presented in ACC 2023. So this program is based on our objective to increase the awareness on bempedoic acid and usage of bempedoic acid amongst physicians and general practitioners. Is basically to upgrade our knowledge on late breaking CVOT trial, that is clear outcomes trial. And we have none other than the best of the best faculty in the field of cardiology, Dr. Tushar Roy. I would like to give a brief introduction of Dr. Sir. Sir is a senior consultant cardiologist, Roy Heart Care Clinic, New Delhi. Over 3 decades of rich experience in the field of cardiology. He is a fellow of International Medical Sciences and many other reputed societies. Many publications to his credit in national as well as international journals. Sir is also accredited as Associate Editor of Cardio Update, formerly Honorary Cardiologist to the Prime Minister of India. And this is just a brief introduction. Dr. Sir is also life member of Cardiology Society of India. So without wasting much of our time, I would like to welcome Sir and hand over this session to Dr. Tushar Roy.
Thank you, Dr. Satish. Today, as you clearly said, we are going to talk about bempedoic acid. And this is a new molecule by which we can lower the LDL cholesterol. How to use it, when to use it is the talk for today. And especially since, as you again mentioned, that very recently, the outcome trial has been published, which is almost 14,000 patients. But before I actually go into that, I would like to give you a little perspective on lipid in general. You know, the first about is the prevalence of hyperlipidemia in India is not very much. And that's a little paradox. It's not much because the increase in LDL is only about 25%. Triglyceride increase is only about 30%. And HDL lowering is almost like 70 to 75%. So we have slight increase in LDL, slight increase in triglyceride, but a much lower HDL. As we all experience in our day-to-day practice, we see HDL levels of 32, 34, 36. Hardly do we see 42s and 45s, rarely 60s, and even more rarely 80s. But the paradox here is that despite the fact that we have lower LDL values compared to the West, we have almost 2 to 3 times the incidence of coronary artery disease compared to the West. Also, younger people from India, and by India, I mean India, Bangladesh, Pakistan, and Sri Lanka, this whole group has been found to have far more prevalence of coronary artery disease compared to any other population in the West. And this is not only true for Indians who are here in India, but also physicians in the United States, twin Punjabis who have migrated to Canada and from Punjab, Indians in the Fiji Islands, and so on and so forth. So we have the highest incidence of coronary artery disease. A little bit about the history. You see, I mean, it's very common now to understand, yes, cholesterol is a problem, it causes coronary artery disease. But way back in 1856, that was the first time ever that Rudolf Virchow, we may know him as Virchow, Rudolf Virchow first made an association between lipids and atherosclerosis. It would be surprising to know that even in the last year of the war, the Second World War, 1944, we had absolutely no idea about the risk factors that led to coronary artery disease. In fact, the President of the United States of America, Franklin Roosevelt, was examined by his physicians, and his blood pressure at that time in 1944 was 220 by 145. All of us will sit up in our chairs when we hear that number, but the doctors then had no clue about hypertension. They said everything is fine. And 6 months later, Roosevelt died and Truman came to power. And immediately after the Second World War, they started the Framingham Heart Study. And from there, we've gained so much more. Again, the first inclination, a hint of a link between lipids and atherosclerosis and coronary artery disease was given in 1956 by Ansel Keys in his famous 7-country study. He did not establish a lipid as a risk factor, but he hinted that lipid could be a risk factor. The first risk factor to be established was smoking in 1960. Only in 1960 was smoking established as a risk factor for coronary artery disease. And in 1961, we had 2 risk factors that were established. The blood pressure was a risk factor, that lipid was a risk factor, both from the Framingham Heart Study. So when this lipid was actually identified as a risk factor, of course, the doctors started investigating how can we reduce this and maybe reduce the incidence of coronary artery disease. The first statin, that was the first molecule. The first statin was nevastatin. That was discovered in Japan in 1970. And the other was lovastatin. That was in 1987. So these are all very recent developments that we had. And once we had these molecules, then trials started coming. And the first lipid lowering trial we had using a statin was in 1994. It was a secondary prevention trial. And this was the 4S trial using simvastatin. And immediately, almost the next year in 1995, we have this primary prevention study, the WASCOP study using pravastatin. So then all the trials came one after one. I would just like to highlight a few of the largest trials and the outcome for those trials, which will convince you of using lipids or statins to control lipids and decreasing the incidence of coronary artery disease. The first, as I said, secondary prevention trial, that means in established patients of coronary artery disease, was in 1994, the 4S trial. More than 4,000 patients followed up for more than 5.5 years. And that showed a 30% decrease in mortality and a 30% decrease in MACE. By MACE, I mean the 3-point MACE, that is cardiovascular mortality, non-fatal myocardial infarction, non-fatal stroke. However, the largest trial was the TNT trial in 2005 that used atorvastatin. More than 10,000 patients followed up for almost 5 years. And it also showed reduction in myocardial infarction, reduction in strokes. The lipid study in 1998 used pravastatin. More than 9,000 patients followed up for more than 6 years. Again, similar results. The all-cause mortality reduced by about 25%, and the MACE reduced by about, again, another 25%. So overall, secondary prevention, we are seeing that the all-cause mortality is being reduced by about 25–30%, and the MACE is also being reduced by about 30%. And I'll have something to say about that. In the primary prevention, that means people who don't have established coronary artery disease, the first, as I said, trial was the WASCOP trial that used pravastatin. Way back in 1995, it was published. More than 6,500 patients followed up for 5 years. Again, the all-cause mortality decrease was about 20%, and the MACE decrease was again 30%, similar to the secondary prevention trials. The largest trial was the HPS trial, 2002, used simvastatin. More than 20,000 patients. It's not a small number. More than 20,000 patients followed up for 5 years, and what was the result? All-cause mortality reduced by 15%. This is primary prevention, and MACE reduction by 30%. Same thing as you all heard about the Jupiter trial, 2008, that used rosuvastatin. More than 17,000 patients followed up for a mere 2-year period. But in that also, the all-cause mortality reduced by 20%, and the MACE reduced by almost 40 or 45%. So what is the summary? The summary from all this is that even in primary prevention, we are getting an all-cause mortality decrease by about 15%, and we are getting a MACE reduction almost about 30%. There are, of course, other trials, but these were the largest. So when should we treat a patient? So you see, we have these guidelines, especially the European Society of Guidelines 2019, which we will see in one of the slides. And it says certain things. For example, it says if the patient has low risk, the target should be 115. If the patient has moderate risk, 100. If the patient has high risk, less than 70. And if the patient has very high risk, less than 55. This is for the Western population. This is not applicable to the Indian population. As I said right at the beginning, that we have a far more risk of coronary artery disease. And therefore, we tend to follow the Lipid Association of India guidelines, which is almost like 30% low. So that would be for a mild risk, the target should be less than 100. For moderate risk, the target should be less than 70. For high risk, the target should be less than 50. And for very high risk, the target should be less than 30. That's correctly heard, 30. So how low can be too low? We all fear, because you see, cholesterol is basically an ingredient from which all the steroid hormones are made, the glucocorticoids, the mineralocorticoids, the estrogens, progestrogens, androgens, they're all made from cholesterol. So you see, there is always a fear that reducing it too much may actually cause harm. But we have seen that there is no J-curve phenomena. What is this? We know that if the patient has hypertension and has had a myocardial infarction or acute coronary syndrome, then reducing the systolic blood pressure to below 120 paradoxically increases the problem rate. So if the BP is high in a patient of acute myocardial infarction, the risk factor is high. As the BP comes lower and lower, the risk gets lower and lower. But beyond a certain point, below a value of 120, the risk again rises. So there is the typical J-curve phenomena that we see. Whereas this J-curve phenomena has not yet been seen in LDL. People have gone down to below 30. In the Fourier trial, even values of 20 and 19 were reached, and there was no adverse risk that was seen in any of these trials. So till now, there is nothing called a low LDL value. So till now, there is nothing called a low LDL value. And there's been studies in which the patients had values of less than 30 LDL, and all the hormones that I just said were absolutely normally being produced. So we have several drugs that control that. We have statins, and we know that maximal doses of statins can reduce LDL by 50%. We have ezetimibe, which by itself can reduce by about 18%. Bempedoic acid, which we will talk about today, about 20%. And PCSK9 is by far the best, 60% reduction in LDL cholesterol. So best is PCSK9 60%, statins 50%, bempedoic acid 20%, ezetimibe 18%. The problem with PCSK9 is that it is very, very expensive. It costs about 40,000 rupees a month, every month, for a lifetime. So this is something that many people cannot afford. But what we can have a niche for that, and the niche is that it is seen that in acute coronary syndromes, a rapid reduction in LDL has been shown to be beneficial. So maybe perhaps for a short period of time, maybe for 3 months or 6 months period of time, to get the LDL down to really low values of 30, PCSK9 can be used for a period of maybe 3 to 6 months initially, simply because of the cost. If somebody can afford it, it's one of the best drugs to use subcutaneously twice a month. But what about combinations? We know, as I said, high dose, maximum dose statins can reduce by 50%. But when combined with ezetimibe, can reduce LDL by 65%. And when again further combined with PCSK9, can bring it down to about 85%. Same thing when statin is combined with bempedoic acid, we can get a 65% reduction in this. Of course, there are other medicines also in the pipeline, inclisiran, metomersen, and so many other medicines which are in the pipeline. Another problem that comes with statin is the adverse reaction. However, the perception of the adverse reaction is actually far more than the actual adverse reaction. Because when we do a study, we compare placebo to the active ingredient. And often you will see, as you will see in the CLEAR outcome trial, that although the adverse reactions was high, but it was similar to that of the placebo. So there was a meta-analysis of statins to look for the adverse drug reaction. And more than 92,000 patients, or 91,940 patients, almost 92,000 patients, over 13 trials were analyzed. And these are the numbers per 1,000 patient years. That means when 100 patients were followed up for 10 years, these were the numbers. The numbers were that 10 events were prevented. Myalgia occurred in 10% of the cases. By myalgia, I mean muscle aches and pains, usually in the major muscles, that is in the thighs or the buttocks, with a CK value that is less than 3 times the upper limit of normal. Serious adverse effect was only 1. New onset diabetes was only 0.2. So 10 events prevented, new onset diabetes 0.2. Myopathy, that is muscle aches and pains with a CK value more than 10 times the upper limit of normal. Myopathy, again 0.2. Rhabdomyolysis, that means, of course, myopathy along with rise in creatinine, 0.02. So the number of adverse reaction is very, very low and almost comparable to actually placebo. So now if you can go, now if you are starting the slide, so this is the first slide, and this is a very interesting slide. It actually shows 2 things, not one thing, and we'll be concentrating on the upper panel only, where there is the year mentioned and the percentage reduction is risk. It says 1 millimole per liter reduction of LDL, which is about approximately, I think it's 36.8, let's say 40 milligram of LDL if it is reduced. Then in 1 year, you will see an 11% reduction in the risk of events. In 2 years, you'll see a 24% reduction in risk of events. In 5 years, 33%, and more than 5 years, 36%. So what's important? What I just told you, that lower is better. Even up to 30, there's no problem. In the Fourier, it went up even to went down below as much to 20 also. No problem till now has been seen. There has been no J-curve phenomena. And the longer it is, the better. So the lower the better and longer the better. And this is what this slide very emphatically shows, that the earlier we get the LDL down and the longer we keep it down, the more would be the benefit that we get from this LDL therapy. Next slide, please. Next slide. Yeah. So do all statins achieve LDL goals as per guided recommendation? Absolutely not. And in the next few slides, I'll show you that even if we use the maximal doses, we are achieving very little. And I'll just give you the numbers in short. With the statins, even with using maximal doses of statins or maximally tolerated doses of statins, goals are achieved in only 30% cases. So we are only able to achieve the goal in 30% cases. When we add ezetimibe, that is maximally tolerated dose of statin plus ezetimibe, we are able to achieve it in about 37% cases only. And if you're rich enough to add PCSK9 inhibitors, then up to 60% reduction, 60% of the people who can achieve their goals. So how to achieve LDL target after maximally tolerated dose of statins? That is the question that we will discuss last. Next slide, please. Next, do all statins achieve? Yeah. So, right. Next slide, please. So here's the slide which shows basically what we're discussing, that the statins added to ezetimibe and even bempedoic acid will lower the LDL further and further. Next slide, please. And of course, PCSK9 is the best of the lot. By itself reduces it by about 60%. Next slide, please. So this is the target goal. Next slide. Yeah. So this is the targets that I've been talking about. So let's forget the 2016 guidelines. Let's look at the 2019 guidelines. The 2019 guidelines, the ESC guideline says that the lowest target would be 115. A moderate risk target should be 100. High risk, it should be less than 70. Very high risk, less than 55. These are not the targets that we follow. Because Indians have far more risk of coronary artery disease, as I said, 2 to 3 times more, established beyond doubt. Our targets are the following: low risk, less than 100. Moderate risk, less than 70. High risk, less than 50. And very high risk, less than 30. So that is our target. And these targets are not met. That means the ESG targets are not met. Let me see how we will meet our Lipid Association of India targets. Next slide, please. Next slide. Yeah. So this is a trial, the Da Vinci study, which basically looked at whether the targets are being achieved or not. That means you have a moderate risk patient or a high risk patient. You have a target in mind, as we have just shown you the ESC 2019 target. Are we achieving it? by the maximum tolerated dose of statin, or by adding ezetimibe, or by adding PCSK9 inhibitor. So this was the Da Vinci study across 18 countries, almost 6,000 patients in primary as well as secondary prevention. Next slide, please. And the goals, as is seen, had not been reached. Next slide. So if you look at the hashed red bar, which basically is the maximally tolerated dose of statin. That is a maximally tolerated dose of statin. Even when it is used, only about 30% are achieving the required goal. Only 1/3 is achieving the goal. When we add ezetimibe to that, I think that's the orange hashed bar, 37% is reached. And if we add PCSK9 to that, that's the blue hashed bar, 57% only reach the target. So we are still what we call the RCR. Now, two terms are there. I won't get into the detail. The RCR is the residual cholesterol risk. That means despite the fact that we are using maximally tolerated dose of statin, maybe adding ezetimibe to that, and it's rich enough, we are adding PCSK9 inhibitors, we are still not achieving the target dose, the target that we are supposed to achieve. We are not even achieving, this is the ESC targets. We are not even achieving the ESC 2019 targets. Forget about a Lipid Association of India targets. Next slide, please. So this is again the same thing with very high risk patients. And here again, the red hashed bar is the high intensity statin. So in very high risk patients, only 22% reach that. And ezetimibe also doesn't make much difference in there. Again, if you add PCSK9, the blue hashed bar again shows that the reduction is about 58%. So we have a long way to go as far as control, as far as reaching our cholesterol goals are concerned. And we still have what we call the RCR, or the residual cholesterol risk. Next slide, please. So here is basically the pharmacology, I can say, of bempedoic acid. Bempedoic acid is a newer molecule. This is what we call an acyl citrate lyase inhibitor. That's one of the enzymes that are before the HMG-CoA reductase enzyme in the liver itself. So we know that from cholesterol, the cholesterol is formed. So it's one of those before HMG-CoA reductase. It is a prodrug. That means it has to go to the liver and it spares the muscle, because the enzyme to convert the prodrug is not present in the muscle. It has no action on the muscle. So it is converted into an active ingredient in the liver itself. It has a half-life of about 21 days and eliminated almost exclusively through the kidneys. So a dose reduction in kidney patients is not required, but the eGFR to which we can use bempedoic acid is about 30. So till 30 we can use. So in the second panel, it says renal impairment. So no dosage requirement is necessary. However, we are generally don't use it if the eGFR is less than 30. Hepatic impairment, again, no dose adjustment is required. But however, it is contraindicated in severe liver disease, that is in childhood class 3. There are a couple of problems, couple of things we should be alert about. One is that it is contraindicated in pregnancy, contraindicated in lactation, and as I said, contraindicated with a GFR less than 30 and a childhood liver class 3. Also, it is contraindicated if you are using simvastatin more than 20 milligram or pravastatin more than 40 milligram. But I think for Indian conditions, this doesn't matter, because hardly any one of us are using simvastatin. I think none of us are using pravastatin. There's a little caution, and the caution is that the bempedoic acid has a tendency to increase the creatinine a little bit, to increase the liver enzymes a little bit, and to increase uric acid. However, if the patient has a history of gout or has got high hyperuricemia, value of 9, 10, 11, then of course one has to be very cautious. It's not contraindicated, but one has to be very cautious, and one has to check the uric acid from time to time. And it's also a good idea to occasionally check the creatinine and the liver enzymes. So here it says prior history of gout, increased vigilance is required. It's not contraindicated, just increased vigilance is required. And of course, on the right side, the red says where it is contraindicated. That I said, simvastatin more than 20, pravastatin more than 40. But as I said, hardly any one of us are actually using simvastatin. And pravastatin, I don't think any of one of us are using. And pregnant and breastfeeding is the contraindication. And there's another contraindication, which is very, very rare. I mean, somebody with tendon rupture or an elderly with the renal failure is a contraindication. This again is something that we don't usually come across. Next slide, please. So it's a reasonably safe medicine, can be used. And here's the CLEAR outcome trial. And the CLEAR outcome trial was presented in 2023 only. So as it says, it's an ATP citrate lyase inhibitor, which is one of the enzymes that come in the pathway of cholesterol formation above the HMG-CoA reductase enzyme. Next slide, please. So it was almost 14,000 patients. And these patients were statin intolerant. So these statin intolerant patients were then given bempedoic acid and compared to placebo. So it was not a bempedoic acid being added to statin. It was bempedoic acid substituting statin in those people who were statin intolerant compared to placebo. So the follow-up was for about 40.6 months. And it proved to be a very effective treatment. And I will tell you the effectiveness of this medicine. Next slide, please. So here we are. So this is basically the baseline characteristics. So median age was about 65 years. The LDL cholesterol was about 139. Both the bempedoic arm and the placebo arms, they were comparable. The eGFR, so CKD, that is eGFR less than 60 ml per minute per 1.70 meters squared body surface area, was there in about 20% cases, but none of them were less than 30 ml. Primary prevention was in 30% and secondary in about 70%. Diabetes was present in about 45%, which is usually what we see in our clinical practice also. Approximately 40% of our patients are diabetic. Inadequately controlled diabetes. Statin use, this is surprising that this was a substitute for statin intolerance. The statin use was also being used perhaps at a lower doses. This was equally in both the arms, about 22-23%. And SGTBB was also used in about 10-11% cases. Next slide, please. So that was the demographic data. And instead of looking at all the curves, we just focus on the left side. So the 3-point MACE, which we commonly talk about, the 3-point MACE basically means that myocardial infarction, non-fatal myocardial infarction, the non-fatal strokes and cardiovascular mortality was reduced by about 15%. So here is a comparison with placebo. It is not being compared with statin. It's being compared with placebo. So compared to placebo, there was a 15% reduction. And that's what I said right at the beginning, that bempedoic acid approximately reduces the MACE by about 15%. Non-fatal fatal MI was reduced by about 23%. And the need for coronary revascularization was reduced by about 20%. Next slide, please. Yes, next slide, please. So as I said, so these were basically statin intolerant patients who were given bempedoic acid and compared to placebo. And this was a CV outcome trial. In the trials that we had before, the CLEAR Serenity, CLEAR Tranquility, they were just efficacy trials. They were not cardiovascular outcome trials, but this was the first cardiovascular outcome trial that we have. Next slide, please. So here we are. So there was a definite reduction in non-fatal myocardial infarction, definite reduction in non-fatal stroke by about 15%. Coronary revascularization was reduced by about 20%, and cardiovascular deaths was also reduced. Next slide, please. So here's the same thing, the same numbers again. So the 3-point MACE reduced by 15%, myocardial infarction reduced by 23%, revascularization need reduced by about 20%. Next slide, please. This is a very important slide. I'll spend a little time on this slide. So as I was saying that the LDL reduction compared to placebo was about 20, 21, 22%. So 21.7%, about 22% reduction. But what is important is that on the right side, that it also reduced HSCL. Sometime back, I talked about the residual cholesterol risk. That means that despite our maximal doses of statin, adding SGTBB, perhaps even now adding bempedoic acid, we are not achieving our target values. As I said, most of the time we are able to achieve the required target value. The ESC target value only about 30% of the time. If we go by the strict lipid association target values, perhaps our numbers would be perhaps 20%. So there we are still left with something yet to be done to reduce the cholesterol value to the required target goals. So we still have a residual cholesterol risk. But we also have what is called the residual inflammatory risk, the RIR. What is this residual inflammatory risk? This residual inflammatory risk is that the coronary artery disease is not only caused by high lipid values, but is also caused by inflammation, ongoing inflammation. In fact, the residual inflammatory risk is defined when the LDL is less than 70 and the hsCRP is more than 2. So the hsCRP more than 2 and the LDL value less than 70, we have still the residual inflammatory risk. And we look at the various trials, they have looked into this actually. They have used colchicine, an anti-inflammatory. They have used methotrexate. They have used allopurinol, and they had also used interleukin, anti-interleukins in 2 of the trials. So certain trials are still undergoing, which are looking at the residual inflammatory risk in reducing the coronary events. And in the 2 of the trials, that is the COLCOT trial and the LODOCO 2, that used colchicine, there was a significant reduction in cardiovascular events. So it's very important. Again, if you see, I told you about the 2 trials. One was the TNT trial, and one was the Jupiter trial. The Jupiter trial also had high hsCRP, and statin, especially rosuvastatin, is well known to reduce the hsCRP. And when it reduced the statin as well as the hsCRP, the outcome, as I showed, was a whopping 45% compared to 30% of the other trials. And here is another trial that we show where the LDL is not only reduced, but the hsCRP is reduced. So it is taking care of not only the cholesterol risk, but also of the inflammatory risk. This is a very important slide that we should keep in mind. Next slide, please. So here is basically the various side effects. And I would like you to compare with the placebo. So there were serious adverse events, 25 is similar to placebo. Adverse effects were similar to placebo. Myalgia, in fact, was numerically more in the placebo. Discontinuation was similar. New onset diabetes was similar in both the groups. Renal impairment was slightly more. As I said, there are 3 things that this tends to cause. One is a slight increase in creatinine, a slight increase in liver enzymes, and a slight increase and an increase in uric acid may even precipitate gout. So here we have the same thing: renal impairment, a little bit more than placebo; the hyperuricemia, a little bit more than placebo; and gout, of course, more than placebo. So these are the various findings that we find. So it's almost like placebo, except in the 3 things that I just mentioned: a slight increase in creatinine, a somewhat increase in uric acid, and a slight increase in liver enzymes. Next slide, please. So this is the conclusion of the trial. Bempedoic acid becomes the first ACL inhibitor and the first oral non-statin to demonstrate statistically significant reduction in MACE events in patients who are at a high risk of cardiovascular disease with documented statin intolerance and elevated LDL-C. So this is the conclusion of this trial, but we as practitioners have taken this forward because we want to see our LDL values at very low values. So we are now combining maximally tolerated dose of statin with ezetimibe and even with bempedoic acid. And I'm happy to say that in many of my patients, I'm now seeing values of 30, 28, 32, which is exactly what we want, and which is exactly what the Lipid Association of India is saying in very high-risk patients, patients who have had few stents, patients who have had an event even after a stent, and so on and so forth. Next slide, please. So here are the very clear conclusions from the CLEAR outcome trial, and that it's well tolerated. As we said, that the discontinuation rate was similar to placebo. There is a significant 22% LDL risk, LDL cholesterol risk, and there's a significant reduction in the hsCRP risk. And we've talked about the cholesterol risk as well as the residual inflammatory risk, and why Jupiter trial with rosuvastatin was so successful as a primary and secondary endpoints. And it's a very, very effective approach if we use a combination of bempedoic acid. So we can use bempedoic acid when statin intolerance with a smaller dose of statin maybe, or we can combine maximum dose of statin with ezetimibe with bempedoic acid to achieve whatever goal we have in mind. Next slide, please. And thank you very much for your patience.
Thank you so much, sir. Thank you. Such a elaborative and the experience and the background you have given about LDL cholesterol management and why it is very important. The flow of the presentation was very fantastic. I would like to, there are a few questions which audience has asked, and that those questions are in front of me. So like you were saying that you are going as low as 29 or 30 milligram per deciliter as per the guideline recommendation. So there was one question: is it appropriate to keep this low, and can it lead to any neurological complications?
Actually, no, because they have looked into this value. They looked at cognition. In fact, I forget, I think it's called the perspective trial. In the perspective trial, they looked at the cognitive function of these patients. And till now, there has been no, I am not aware of any study, any trial that has showed that this is the bad outcome of such a low value. Even up to 30, they have found no J curve till now, no cognition problem, no decrease in formation of sex hormones or mineral corticoids, glucocorticoids. Till now, nothing has been achieved. In fact, neonates and there are certain gene mutations which for their lifetime, they have an LDL value of 30 and they have absolutely no problem. They procreate normally. All other bodily functions are absolutely normal. So till now, we don't know what will happen if values are there of 15 or 16 or 12. We don't know. But till 30, there is enough and more evidence, especially the Fourier trial, where values of even 19 and 20 were achieved. There is no problem. Right now, we are stopping at about 30, 25, and we are not going below that. But we've not had any problem as far. Neither does the literature say that there is it.
Thank you so much, sir. There's next question which is being asked is what percentage of statin intolerance you actually observe in your routine practice? Because it's already very high, very difficult to find out what is statin intolerance is. And how you check it, and can bempedoic acid be the choice of this?
Yes. So first of all, regarding statin intolerance, it's a very vague term. You see, whenever there is muscle aches and pains and people are now aware, they've got WhatsApp messages, they look up Google, etc. So they can come convinced to you. They come to your clinic convinced that it is because of statin. Whereas, all the trials have shown, every single trial, there was another trial, I think it was a strength trial, and this meta-analysis that I mentioned of 92,000 patients, then they showed that the myalgia it was about 10%. But the myalgia was as common in the placebo. Even you see here in the bempedoic acid, it's as common in the placebo as in fact, in some cases, it was numerically more in the placebo than here. But the patients come so convinced in their mind that so you try to convince them any other way, it doesn't succeed. So you have to, work with the psychology of the patient. And of course, you substitute it. You say, okay, I'll reduce the dose. Definitely this will get improved. And then you add maybe ezetimibe or bempedoic acid to that. So either of them are good, but since ezetimibe has been with us for a long, long time, so our tendency is to add ezetimibe first. And if that achieves the goals, fair and good. Otherwise, I have no hesitation in adding bempedoic acid. I've been doing this even before the CLEAR outcome trials came. And I'm very happy to see the numbers. And I'm not at all afraid of numbers like 40 or 30.
Thank you so much, sir. Next question is, what percentage of LDL reduction you observed in patients with in actual routine practice? Because trials are saying that there's 38% reduction with bempedoic acid plus ezetimibe. So
actually we are seeing those values. We are seeing those numbers. Like they say that maximum reduction with maximally tolerate maximum dose of statin is about 50%. That's exactly what we are saying. We start with 140. We are seeing about 72, 75. We are achieving with 40 milligrams of rosuvastatin, right? If you add ezetimibe to that, we can get 65% reduction. And then maybe we don't know how much will be reduced if you do 40 milligrams rosuvastatin plus 10 milligrams ezetimibe plus 180 milligrams bempedoic. How much will be reduced? We don't know. But we know with PCSK9, it is a 65% reduction, 85% reduction. If it's 3 added, perhaps with bempedoic acid, it will be 70% reduction, 75% reduction. So yes, we are seeing those values. And till now, touch wood, we have not had any problems in most of our patients.
Thank you, sir. Thank you for giving confidence to the audience about usage of bempedoic acid and ezetimibe along with maximally tolerated dose of statin. Next question is, what percentage of statin intolerance? Actually, this question is again repetitive question. In routine practice, how much bempedoic acid is safe for use in longer duration, and is it having any benefits in more benefits in diabetes mellitus patients?
I'm not sure whether it has more benefit in diabetes mellitus, except that because diabetic patients are at higher risk, and therefore reduction of LDL will convey to them a greater risk. So it's basically how much LDL you have reduced. I don't think it's to do with the higher risk in diabetic patients. Longer, we don't know, because even this trial was for about 40 months. We are actually using it practically for maybe 6 months, 8 months, 9 months. So we ourselves do not have longer experience. Neither did this trial. More than 40 months was the average duration of the trial. So we really don't know what will happen in 5 years, 6 years, 10 years. We don't have the statins we are using for a long period of time, for 20 years maybe. So we have much elongated data on statins, but we don't have on bempedoic acid. So still an open question as to what will happen in the next 5 years, 10 years.
Next question is they're asking about there's a patient, type 2 diabetes mellitus patient. He's also hypertensive. So my patient's LDL cholesterol is around 190 milligram per deciliter. So is it appropriate to keep
okay
as low as
so what I do is I use the Framingham risk score. So basically to find out, for example, this patient has diabetes and hypertension. Now, if you go to any app, I suggest the Medscape app. You can download it right now. The Medscape app, you just go and say Framingham risk score, it will give you the Framingham risk score. So you just fill in gender so-and-so, HDL so-and-so, total cholesterol so-and-so, patient is hypertensive, on medication for hypertensive, diabetes, etc. So you fill it up and it will give you a number. That number is the risk over the next 10 years. So it gives you the 10-year risk. But in India, as I said, these are for the Western people. In India, we have a higher value. And therefore, in India, we have a multiplication factor. And that multiplication factor has been given by the International Atherosclerotic Society and accepted by the Cardiological Society of India. So we have a multiplication factor. For an urban male, we multiply this risk score that we get from the Framingham risk score multiplied by 1.8. And for a lady, we multiply by 1.54, 1.81, 1.54. And that gives me the risk factor actually. That means this is the risk the patient is having over the next 10 years. So if this is less than 10%, we say low risk. If it is more than 20%, we say high risk. And if it is between 10 to 20%, we say moderate risk. So then your numbers fall into place. As I said that we are now, at least I am following the Lipid Association of India, not the ESC 2019. So if the patient has mild risk, less than 10%, then my target would be less than, how much is it? So if it is very severe, it will be less than 30. So more than 20%, it will be less than 30. If it is 10 to 20%, it will be 50. If it is beyond that, it will be 70. So most of my patients, unless of course it's primary prevention, young person, then maybe I'm accepting 100. But if the patient is diabetic and hypertensive, I think the minimum starting should be 70. And if it is high risk, it should be 50. If it is very high risk, a person who has got a stent, etc., then it should be 30. So the way to calculate that is we get the Framingham risk score, and that is easily available in a Medscape app. You download it from Google Play. And to that, you add or you multiply the value that you get by 1.81 for an urban male and 1.54 for an urban woman. There are other values for rural men and rural women. So then you'll get the risk of an event in the next 10 years. So less than 10% risk, low risk, 10 to 20% moderate risk, more than 20% high risk. And you have the values that you have to achieve at these various risk levels.
There's a last question audience has asked is it safe to use bempedoic acid in mild to moderate CKD patient?
Yes. See, basically, it's absolutely safe. And not only is it safe, the dose need not be reduced. It's a single dose, 180 milligram. Only if the GFR is less than 30, then it should not be used because it hasn't been used in any of the trials. So, and the excretion is 70% from the kidneys. So therefore, it is better at the present time not to use it below eGFR value of 30 ml per meter per 1.73 meter square body substrate.
That's great indeed talk, sir. And before any concluding remarks would you like to give before we call this session?
So concluding remarks, as I said, that we should calculate the risk that is involved in our patients. We should formulate in our own minds which target I will follow, whether I will follow the ESC 2019 target or whether I will follow the Lipid Association of India target. It's up to you. I personally follow the Lipid Association of India target because I believe that the Indian people are far more risk, and that's what the evidence says. But you decide on which one to follow, and then set your target. And based on the target, see that the target is achieved, and sequentially increase maximal dose of statin, add maybe to that, add bempedoic acid to that, and see that you can achieve that target. Because with the statin, especially with rosuvastatin, you are not only getting LDL reduction, but you are getting anti-inflammatory action. With bempedoic acid, also you're getting anti-inflammatory action. So you're tackling actually two heads. One head of the residual cholesterol risk, and the other head of the residual inflammatory risk. So that's what I suggest to my colleagues.
Thank you, sir. Thank you so much. It was indeed a pleasure having you on this event called CLEARTalk and clearing all our doubts about bempedoic acid, about the usage of other statins, high intensity statins, and how to achieve the desired and targeted LDL cholesterol goal. And that's very important for all of us to understand, to decrease the residual risk, as you said, sir. And we are we are very sure that our delegates would have definitely got enlightenment with the knowledge you have imparted. And usage of bempedoic acid can be made possible wherever it is required. At the same time, we would like to thank all the delegates for your active participation and your presence. And thank you all once again, and thank you so much, sir, for giving such a beautiful and wonderful talk. And hoping that all audience questions are answered. If you are having any questions, you can always reach out to us, and you can always comment in the comment box so that we can answer these questions very shortly. Thank you, sir, and have a wonderful day. Have a wonderful evening.